My topic today is preventive cardiology, and I'll be focusing on the new European guidelines. I'm Lale Tokyozolu from Hacettepe University, past president of the European Atherosclerosis Society. Atherosclerosis is a chronic, risk factor-driven disease which may ultimately lead to acute coronary syndromes. And the management of the disease has changed in the past decade. So we have now shifted from a lesion-focused approach to a patient-centered approach where early detection and prevention are essential. The European guidelines have been updated in 2021, and in the new guideline, there's more personalized prevention since one size will not fit all. There are now age-specific risk thresholds for healthy people. The risk stratification system has been completely updated, and more attention is given to older individuals because the population is aging. LDL cholesterol goals are the same as the 2019 dyslipidemia guideline, and there is a lot of emphasis on shared decision-making with the patient. SCORE2 and SCORE-OP are the new models to estimate the 10-year risk of cardiovascular disease in Europe. They have been updated to use the most contemporary data and estimate 10-year risk of total cardiovascular events, whereas the previous SCORE system could estimate only fatal events. The charts are available for 4 European regions ranging from low to very high risk. And the competing risk-adjusted SCORE elderly persons can calculate risk up to 90 years of age. Here you see the SCORE2 chart, and looking at parameters like non-HDL cholesterol, systolic blood pressure, smoking status, age, and sex, the 10-year risk of the patient will be determined. However, some patients will be automatically at very high risk. So there's no need to use the SCORE system in these patients. Those with established atherosclerotic vascular disease, diabetic patients with target organ damage, and severe chronic kidney disease patients will be automatically at very high risk. After risk estimation, taking risk modifiers and age into account, the treatment goals are individualized for each patient. Risk modifiers such as psychosocial stress, imaging, and comorbidities are taken into account. To this guideline, new risk modifiers have been added, such as migraine with aura, or sex-specific conditions such as history of premature or stillbirth in women, preeclampsia, gestational diabetes, polycystic ovary syndrome, and erectile dysfunction in men. Air pollution is also a risk modifier in the new guidelines. Here you see the healthy diet characteristics, and underlined are the ones that have been updated in this guideline. Adopting a more plant-based and less animal-based Mediterranean diet is recommended. Minimizing saturated and trans fats is important, and red meat should be reduced to 350 to 500 grams a week, especially if it's processed. Increasing fiber, fruit, and vegetables is important, and eating fatty fish should be performed at least once or twice a week. Sugar-sweetened beverages are discouraged, and as a novelty, alcohol is restricted to 100 grams a week. Less than 5 grams salt a day and 30 grams of unsalted nuts a day, unless caloric restrictions are present, is recommended. Physical activity is also extremely important, and adults of all ages should strive for at least 150 to 300 minutes a week of moderate intensity, or 75 to 150 minutes a week of vigorous intensity exercise. But if an adult cannot do it, at least they should try to stay as active as their abilities and health condition allow. Even if an adult exercises, reducing sedentary time and engaging in at least light activity throughout the day is encouraged. And additional resistance exercises done twice a week are recommended. There are specific recommendations for patients who have risk factors or established cardiovascular disease, where the recommendations can be tailored. Smoking cessation is recommended regardless of weight gain because weight gain does not decrease the atherosclerotic benefits of smoking cessation. The LDL cholesterol goal are the same as 2019 guidelines. In patients with high and very high risk, at least a 50% reduction from baseline with a goal of less than 1.4 millimole per liter in very high risk and less than 1.8 millimole per liter in high risk is recommended. In addition, we also have secondary goals for non-HDL and apoprotein B. These are especially important if the patient has insulin resistance, because here LDL may not capture all the atherogenic risk. In apparently healthy persons, goals are individualized and there's a stepwise approach after which the ultimate blood pressure goal should be less than 130 millimeter mercury if tolerated, and LDL goal according to the risk of the patient. To get to this goal, first, a highest tolerated dose of statin to reach the goal is recommended, but if not adequate, combination therapy may be utilized. And although the approach is stepwise, stopping at the first step is inappropriate. For patients with established atherosclerotic vascular disease, in addition to lifestyle antithrombotic therapy, systolic blood pressure and LDL should be reduced with an ultimate goal of less than 130 for systolic blood pressure and less than 55 milligrams per deciliter for LDL cholesterol. And treatment can be intensified based on residual risk. To get to goal, statin and if not adequate, ezetimibe and PCSK9 inhibitors are recommended. For the first time in a guideline, there's also a recommendation for anti-inflammatory therapy if the patient's other risk factors are insufficiently controlled or if there's recurrent events under optimal therapy, but this is only a class 2B recommendation. We know that even secondary prevention patients are not homogeneous in their risk, and the risk may range from 10% to 90%. So now there's the smart risk prediction system, which is quantitative and validated. Looking at a few clinical and biochemical parameters can correctly estimate the risk in secondary prevention. However, for patients with atherosclerotic vascular disease who experience a second event within 2 years while taking maximally tolerated statins, now a stringent LDL goal of less than 1 millimole may be considered as a class 2B recommendation. So in conclusion, adopting a healthy lifestyle, starting early on in life and continuing throughout life is very important for cardiovascular prevention. Risk factor control, getting to guideline recommended goals, and staying there will decrease cardiovascular events significantly. Thank you for your attention.